In the world of PAD treatment, artificial boundaries often separate vascular surgeons, interventional radiologists, and interventional cardiologists. But patients with peripheral arteries disease just really don't care about practice titles or specialty distinctions. They just simply need a physician who will do everything possible to save their limbs and improve their lives. It's a debilitating disease. It's poor circulation in mainly the legs, causing leg cramps and leg pain and neuropathy. And it makes it really difficult for patients to walk. So it's really about how do you relieve my pain and give me a better quality of life? That's what the patients care about. Well, tonight's award transcends all of these traditional practice divisions to truly just recognize excellence in PAD care in its purest form. A physician who consistently goes above and beyond for every single patient, regardless of specialty framework. Dr. Nicolas Mouawad exemplifies this patient first philosophy. As chief of vascular and endovascular surgery at McLaren Health System in Bay City, Michigan, he has certainly earned impressive credentials, including recognition on Newsweek's America's Best Vascular Surgeons list. But what truly distinguishes him, I think, is his relentless commitment to exploring every possible option for limb salvage when others might consider the case hopeless. Consider a patient that came to us, the Global PAD Association, who was scheduled for amputation at another hospital. When I messaged Dr. Muad about it and he learned about the whole situation, he immediately offered to help, even preparing for a potential hospital to hospital transfer if necessary. Well, the patient, it turns out, the amputation was not necessary in the immediate sense. Life was not on the line. So the vascular surgeon at the other hospital discharged the patient so that this patient could go and get a second opinion to see if anyone else had any other options. Well, Dr. Muad stepped up and said, you know what? If no one else will try, I will try. And he quickly provided intervention using advanced techniques that others had not considered. And today, that gentleman walks on his own 2 feet. This story repeats itself throughout Dr. Muwad's practice. We see it over and over and over again. His ingenuity shines brightest when conventional methods fall short. He actively participates in cutting edge research to create new possibilities for patients who have been told that nothing more can be done to save their legs. And what again makes tonight's award so special, so meaningful, is that it really stems directly from patient testimonials and real world outcomes. While medical journals measure success through statistics, patients consistently describe Dr. Muad as someone who sees them as a whole person with unique goals and preferences. In emergencies, he remains accessible when minutes matter as well. He just quite simply puts patients over politics every single time, even over his own personal life sometimes. I know that. Demonstrating that true excellence in PAD care requires both technical brilliance and just profound compassion. The PAD Doctor of the Year, the PAD Doctor of the Year Award, celebrates a physician who embodies what matters most in this field, an unwavering dedication to preserving limbs, restoring mobility, and maintaining quality of life, regardless of medical specialty or practice model. So please join me in offering a very warm and well-deserved congratulations to Dr. Nicolas Mouawad of Bay City, Michigan, the McLaren Hospital Systems, our PAD Doctor of the Year. Congratulations, Dr.
Uh,
Mouawad.
Thank you so much, Kim. Really, thank you so much. This is really is a honor and a privilege, and really, I'm just doing what I wish somebody would do for me, what we would want somebody to do for our family. So I really appreciate this honor and this recognition. But I'm just doing my job and trying my best to give people the quality of life that they deserve, that they want, and I really just want somebody to try. That's all. That's all I'm asking for. That's all I'm trying to do. So thank you very much.
It's interesting in a world where so many doctors are resting on their laurels and waiting for evidence to be created, saying, hey, there's not enough evidence to do this or that to save a limb. You're saying, hey, you know what? I'm going to dive right in and I'm going to help create the evidence, if it's at all possible, for new advanced methods when an amputation is already on the line, a patient is on deck, no one else can do anything else. Your philosophy is, why not try?
Completely agree. I mean, I think when the amputation is on deck anyway, I always tell them, it's like, hey, look, if you're willing to try and you're ready to go through this, I'm willing to try for you. So we can try this together. And if, if for some unfortunate reason things don't work out, then we're back to where we were in the first place anyway. So I don't think we lose anything, but I would want somebody to try. Of course, we don't want to subject people to things that are futile. We don't want to subject them to things that may not work or overwhelmingly not work. But if there's an opportunity, a 10%, 20, 30% chance, it's better than zero. And I would want somebody to try for me if I was willing to go through that myself.
And also, if you have a patient that's willing to be a partner in their care, and when you get these patients, and the patients that we're talking about right now are the ones that are in advanced stage PAD, known as critical limb ischemia or critical limb threatening ischemia, they need to be partners in their care, because you will have to have the conversation. If there's a patient that's coming back every 6 weeks for another procedure and another procedure, another procedure, and you're saying, hey, wait a minute, I've done my part here. You're not compliant with your medication. You're not even trying to move your feet and flex and point and draw the alphabet while you're healing a wound. You're not willing to change your diet. You're still eating at the local fried chicken place and grabbing a beer every single evening. And you know, you need to kind of sometimes go, call it, or have a very serious heart to heart with those types of patients. I mean, we're talking about patients that are literally trying. They just don't know where else to turn. They just need someone to believe in them.
Totally agree. I mean, this is, as you well know, atherosclerosis is a progressive disease, particularly those that have critical limb ischemia or CLTI. They are going to lose the limb if you don't do something about that. We know that the natural history of patients in end stage PAD is critical limb ischemia, and something needs to be done, whether it's optimizing medical management, having a
Yeah.
discussion with them, making them part of the team. I mean, we're in this together, and there has to be some effort on their part. And like I said earlier, I'm willing to try if you're willing to try, but we can't, this won't work, with me alone or you alone. We have to kind of work on this together, kind of a patient-centered, family shared type decision. And when you have that conversation eye to eye, everyone wants the best for themselves, and most patients will tend to comply. You know, I think you have to be able to discuss it with them, at a level that they can understand. We have to be able to get to a compromise that's going to work for them and that's going to work for their ultimate care. So I think that's very, very important. Telling them what to do doesn't work. They got to be on board, just like you need to be on board.
Do you face any sort of resistance within the hospital system, or, within societies or anything, to the efforts that you take to try and save a limb?
Yeah, I mean, I think, even with, financial pressures can be difficult. A lot of newer devices
Yeah.
can be financially challenging. Clearly, we don't want to put that, burden on a patient, but, how much is a limb worth? I mean, these type of conversations, they're difficult conversations at times. And like I said earlier, I would want somebody to try for me. So if there's any way for us to be able to do something, we should. And if, that ends up being a significant, concern, then that is a conversation you need to have, with either your health system, with your colleagues, and with the patients themselves. Of course, if we're going to go through these difficult, procedures and obtain these difficult financial resources, there has to be some sort of compliance on both people's parts to understand, hey, this is a big deal. It's not, we're not just doing this willy-nilly. And so when you bring that conversation, people will tell you, hey, look, I want whatever it is to make sure this will work for me. I want it to try.
Yeah, I think that's so important. Do you think do you see in our lifetime it becoming status quo, where limb salvage becomes the priority?
Well, I think I hope so. I guess what it comes down to, limb salvage really should be what we should do. That's the ultimate goal all the time. I mean, more importantly, we want to avoid people to getting to this situation in the first place, obviously. So prevention is key whenever possible, of course. But the de facto should be limb salvage. I mean, everybody wants to have their limbs. You expect that, but a lot of people are worried about prolonged or protracted or futile care. And I think being up to date with what is possible, not just with scientific data, but also with clinical data, medical technology, new innovations, and trials, it allows you to be at the cutting edge of what is
Yeah.
possible and might allow patients, an opportunity that may have not been present previously.
And, we also want to make a very clear point. You bring up something very important that there's a really big problem in terms of the diagnosis, right? Catching these patients early. And I just had a great conversation earlier today with Representative Kim Schofield, who is on the Georgia House of Representatives. And today she made the proclamation for PAD Awareness Month in partnership with the Global P.A.D. Association. And we talked about the need for what was just done in Illinois. If the nation's capital is stalling in terms of legislation to require PAD testing for everyone at risk at a certain point, in their 40s, whether they're having trouble walking or not, or having the traditional textbook symptoms. But hey, you're at risk. Let's start checking those foot pulses now. We were saying Illinois actually became the first state in the nation to make that a requirement. And then um, Representative Schofield was saying, hey, you know what? We need to do the same, and we're going to follow the lead of Illinois, and we're going to do the same. I would love to see you lead that charge in Michigan if you haven't started that already.
So we will be delighted to do that. We've been very aggressive about that. We believe the way to, move the needle is with policy. It's also with engagement to the wonderful things that you and the organization is doing to increase awareness and education, not just the public and patients, but well, not just the patients only, excuse me, or to other medical personnel, but to the public as well. I mean, this is a public health crisis. We are behind the eight ball, unfortunately. PAD is going to be more and more prevalent. And in fact, that's a testament to our medical care. People are living longer because our medical care is better and better, but there are now diseases that are much more prevalent because they occur with age. They're age-related diseases that are progressive. So we expect to see more patients with this, and we need to be well equipped for that. People need to be trained earlier from a medical perspective, but patients also need to be empowered to know that, hey, listen, this is something that I want to prevent if at all possible, or be aware of it or screen for it early in an effort to avoid the long-term or late sequelae, which could result in amputation and a significantly decreased quality of life.
Yeah, because people don't realize, and I think this is a good opportunity to share. We're always big proponents of catching it early and conservative treatment first. Because if you get a patient, you start doing procedures, and they're not good partners in their care, they're not walking already, they're not trying to walk, they're not showing that commitment, then it's just going to be that revolving door of procedures. So catching them early, there's so much patients can do on their own with the support of their vascular surgeon to walk, 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 grow their collateral vessels, eat well, stop smoking, and control their diabetes. And they may never need a procedure down the road. They're going to put you out of business, Dr. Mawad.
Hey, I'm okay. I'm okay with that. I don't mind working less. How about that? I'm teasing. Even but you bring in a perfect point. Will they walk, walk, walk? If there's any opportunity to keep this conservative, that's what they should do. Even if you have depressed ABIs or studies that show that your flow is poor, if you're doing well and you're able to continue your activities of daily living because you have a rich collateral network, because of your aggressive ability to continue to walk in a supervised exercise program and manage your sugar and manage your diet and all that type of stuff. And that's great. That's fabulous. Even if your numbers are somewhat low, you're able to continue the things that you want to do. And that's a win.
Yeah. So I want to get into a few more specific questions to get you to share a few stories. We
Sure.
love good stories.
Sure.
And we always find that asking about a case that you learned a big lesson from, whether it was a success or failure, brings out a really good story and a lesson for that you not only learned, but other physicians and clinicians could learn from.
Oh yeah, sure. I think I mean, I think of several things, but I'm always been very excited about being at the forefront of medical technology and medical education, because nowadays there are patients that we see nowadays where or that I think of years in the past that had I had some devices that are currently available, either on the market or in research, I feel like we would have been able to give them not just a good result, but also a durable solution. And I think being well tuned to that, not just rigorous scientific data, which is of course important to move the field forward, but also, like I said, medical technology being involved with clinical trials, I think is very, very important. So I could think of many, many cases. I would like to say in the past, were very challenging at the time, and nowadays, because of our aggressive involvement with other colleagues, with organizations like yours, with medical technologists and industry, we've been able to now develop devices or procedures or programs to help solve some of these problems that were much more challenging in the past.
So, what's a case that still keeps you up at night?
So, lots of cases, to be honest with you, Kim. Lots of cases. Hey, you know what? I'm gonna keep it actually relatively general for you before I get into some more specific stuff. But the cases that keep me up at night are the people that think that nothing can be done for them, and so they don't show up. And by the time they show up, it's way too late. And I think that's very, very challenging because it's like, hey, had you just made the phone call, you had asked somebody, gotten online, gone to a support group, this problem would have been much more simpler to solve 3 weeks ago, 6 weeks ago, a month ago than it is right now. And so that tends to be challenging. But of course, more specifically nowadays, patients that still have to have repeat procedures or have challenging anatomy that require high risk bypasses that don't necessarily have a partnership in their care, those always tend to keep me up at night. High risk bypasses, those are tough, on the surgeon and on the patient as well.
So, describe a case where a patient should have been diagnosed with PAD sooner, but wasn't. You're going to name every case. I know you are. And because of that, presented on deck for complex revascularization or amputation. And it's really to raise awareness of the kind of the stereotypical diabetic neuropathy, gout,
Oh,
back
I,
issues,
I
arthritis.
I mean, those are too much to even mention. But I could think of several where people will have a significant amount of back pain, or it's been relegated to sciatica or buttock or leg pain. It's been going on for a while and a while and a while. There's no formal vascular examination that happens. These people actually undergo either ortho spine surgery. They have pain stimulators implanted, et cetera, et cetera. And then a straightforward, simple vascular evaluation will show that there's an occluded vessel, and the symptoms can all be attributed to that particular vascular distribution or that vascular anatomy. And so all of a sudden you fix it with a relatively straightforward procedure, either an angioplasty or a stent, and all of a sudden their symptoms are completely resolved, although they had undergone multiple other procedures in the past. So I think screening and more importantly awareness, particularly for lower extremity discomfort and pain, is critical for patients. And if you're not sure, ask. And even as a provider, it's important to give everybody the opportunity to ask and even talk to more people if it makes them feel more comfortable.
I can't tell you the number of patients that have come to us and so they've had a spinal fusion that didn't solve their problem and found out later it was PAD and they didn't need the spinal fusion and that made matters worse. So it's always good to get second and third opinions. And no matter what, always, especially if you have risk factors, go ahead and get
For
your
sure.
pulses checked.
And in my clinic, I'd rather see 100 normal cases that are seen ahead of schedule than to see one or two ones that are that should have been seen soon, seen earlier. And what I mean by that is I tell all my patients, it's like, hey, look, you're coming here, you're getting checked. We should always end up seeing everybody first, because if you wait too long, you can lose your legs. Fortunately for you, you don't need me, because your vascular exam is totally fine and it's probably something else. But the reason you're here first is because if we wait too long and you have a vascular problem, if you have significant PAD, the delay in that care can result in something detrimental down the line.
You sound like a doctor that would have a great motivational speech for walking for all of your patients. You want to give it a shot on me?
Oh, absolutely. So the first thing is, you may have trouble with your lower extremity. You have some blockages in your blood flow, and it's not dangerous. It's a quality of life issue. There's no doubt about that, and it can affect you dramatically. But what we know is if you have a significant blockage, by forcing yourself to walk more and more, At that point, your body will find ways to send blood around that blockage and get you back to at least having some sort of activity that you're comfortable with. Now, we're so used to in this society that if you have pain, you stop, you worry, all that kind of stuff, and that's understandable. But what I'm telling you here is when you have that pain in your leg, I want you to walk some more and force yourself to walk a little bit more because now your body is starting to develop these extra branches, which we call collaterals, to help restore blood flow to your legs. Believe me, if you had to have an operation done, we would do it, but you don't want to have an operation. And if we can avoid it and get you back to as close to activity as you want, then we should maintain this conservatively. Now, that's different than if you have sores or wounds or what we call rest pain, but just difficulty with walking on its own, it's a quality of life issue. And I would recommend we avoid a procedure if at all possible.
So I bet you have a couple of stories of patients who really impressed you with their effort to improve their PAD prognosis through their own perseverance. You want to share a story that would
Absolutely.
inspire?
Oh
Yeah.
yeah, absolutely. I think, surgery is scary for everybody, even for, for surgeons, nobody wants to undergo a procedure if they don't absolutely have to. And I think by empowering patients, I can think of a couple of patients of mine where I always say they come in with a diagnosis of PAD, they automatically think that it will result in an amputation down the line. And so I think to discussing it with them, explaining to them what it is, educating them will make them, will empower them to be better, advocates for their own health. But I can think of a few where I'm like, hey, look, we're going to give you 6 weeks. I want you to go. I want you to force yourself to walk more as much as you possibly can and give yourself a shot. I don't expect you to be able to do it today or tomorrow this week, but give it a week or two and try your best. And let's come back. And at that time, we'll talk and we'll see how you're doing. And lo and behold, most of them like, doc, I feel like I'm able to do the things that I want to do.
Yeah.
Some people will say, hey, look, I can't do everything. I don't feel like I'm 20 again. I think that's a hard thing. You'll tell some patients like, in their 60s, I was like, you're not going to feel like you're 20 again. And I think that's a hard realization for a lot of them, which I find funny at times. But you'll be able to at least do the activities that you want to do. And most of them, feel that way, and they feel proud because they feel like they helped fix their problem. They're involved in their care in the sense that they're trying to walk and push themselves to do so. Importantly, and I always reiterate this to my patients, hey, look, if you get to a point where it's not good or you're concerned or you're worried, call us. We're the experts. We will figure this out together. So don't feel like we're not going to do something for you. We do want to do something for you, but we want to do what's safest and what's less risky first. And if we have to escalate that type of care, then at that point, we'll have a discussion about what else we can do. So lots of stories about that. I'm proud of a lot of my PAD patients because they really try their best. And some of them reach a plateau where they just can't do anymore. And that's okay. That's when we get involved. And that's when it's time to maybe escalate the care if at all necessary and safe.
So share a defining moment in your career. What we call the 6 minutes that matter. What was an inflection point, a conversation that you had, a patient you dealt with, a college roommate that might have had a funny moment with you? What was an inflection point for you or a defining moment in your career?
A defining moment in my career, particularly when it comes to being involved in limb salvage, I'll tell you, is in our community, in our area where we have a big catchment area, and what really kind of dinged the light bulb for me is a lot of patients get referred. They get referred for an amputation. They don't get referred for a vascular evaluation. They don't get referred for a assessment or imaging. They get referred for the amputation. And yeah, and because a lot of times vascular surgeons are the ones that do them, whether it's orthopedic based, trauma based, infection based, diabetic based, or vascular based. A lot of times, they get relegated to us for non-vascular reasons, if you will. And I had a slew of these referrals or consults for these patients where they didn't need it. And the leg required a lot of work, but we were able to save them. And it was at that point where I was like, wow, really, it's not necessarily the procedure. It's that they're being they're so that's because they showed up at my shop. Maybe if they
Yeah.
were somewhere else, a form of vascular evaluation and assessment, imaging, et cetera, may have not been done. And so there may have been people that unfortunately would have lost a limb. Now, that may have been the
Yeah.
case anyway, but at least some sort of workup or some sort of attempt, I think, should be performed if it's not, of course, futile. But if there is any opportunity at all, so I remember those a lot. It was a time many years ago, but it was in succession that several of them were coming. Then we at that time I was like, well, we need to do something more for them, and we were successful at helping them.
It's interesting. We see this across the country, and I deal with a lot of really small community hospitals where larger tertiary centers are quite a distance away.
Right.
And you just have a general surgeon on duty. You might have a vascular surgeon that's shuttling between three or four different community hospitals. You may have an orthopedic surgeon. And we've had quite a few conversations with these doctors to say, there is, hey, have you ever thought twice about amputation? They're like, well, it's the only option we have. And we can't actually discharge this patient because they need something done. And this is what we can offer them. And we've been able to work with some of those doctors to get the patients transferred to a larger tertiary center where there is a surgeon available or such. And they're very willing. But I think that we do need more education out there on the availability of these options. So that it's not us just having to say, when the patient is on deck for amputation, they're calling us to say, whoa, is there any other option for me? It'd be great for these doctors to know that there are other options available and what those options are for advanced limb salvage, and that there are surgeons at nearby places that should be called in for, a secondary assessment to see if there's anything that they can do.
Yeah, I mean, it all comes with that. I mean, it has to start with access, right? You need to be aware of it in order to be able to come up with some sort of a plan. If they're not even getting to you or they can't get to you, then of course that makes things much more complicated, unfortunately. So I think access and awareness is critical. Education and patient empowerment, is just up there, just as important.
And I have one more just fun question for you. And then we're going to take a break and we have a surprise for everyone. You're not going to see it live, it turns out. But if you subscribe to our channel at youtube.com/, the @ sign, the way to my heart, we're going to have a special interview coming up with one of his very special patients that he went out of his way to save. So make sure to watch out for that. But meantime, the final question in this session, talk about a moment with a patient that still has you just shaking your head. Something that patients can learn from. Patients wanted me to ask this question because they want to know, well, what mistakes are other people making and what can they learn from? I mean, it can even be a funny story. I can't believe a patient did this or that. Um, or said this or that. We want to make sure it's respectful so people don't fear going to the doctor. But um,
Yeah.
is there something that the patients can learn from, one that just stands out in your mind and still has you going, "Oh my goodness."
Yeah, yeah. Well, I think, you know, I can think of a patient, that again also, was facing an amputation, and I think sometimes patients, of course, should have trust in their healthcare provider. It's your most valuable asset, your health. But sometimes, if you're not comfortable with the plan of care, I think a lot of people are worried about saying, "Hey, look, I'm not sure about this. Can I have a second opinion?" And I encourage patients to have a second opinion if they're not sure, if they're not happy with what the plan of care may be. There's nothing wrong with that. I think at the end of the day, you want to be comfortable with the ultimate decision and not regret it, particularly if it's something that can't be undone down the line. So I can think of scenarios like, hey, you know what? I'm happy I came to you. This is what I was told I was going to have done. And I wanted to have a second opinion, and we're here. We're discussing another option, which would involve a vascular assessment and evaluation. Of course, not all of those are ultimately successful down the line, but at least they felt comfortable. Like, you know what, we checked this, we checked that. I feel like I've had an opportunity to ultimately come to the realization that there may not be something more that we can do, but I feel like we weren't rushed into it. That slowly, that conversation came up, and I do think about that a lot because I think it's important to really involve them and engage them in their care.
Wow. And I think everyone knows why. You are not just vascular surgeon of the year, but you are truly, truly our PAD doctor of the year, CLI doctor of the year, I should say. Dr. Nicolas Mouawad, we appreciate you so much for being here. Thank you for all you do to save life and limb.
Thank you, Kim. Thank you all. And thank you very much for this recognition and this honor. I really do. On behalf of my patients, I say thank you.